Hello, I'm Bob Challoner, the Chief Administrative Officer at Stony Brook Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the events, people, and services at your community hospital. It's been a great pleasure bringing members of our medical staff to this show and introducing them to all of you, and many of them have been newer members of our medical staff, and today I'm thrilled to welcome one of our, I won't call him older, but I will call him senior members of the medical staff, who is a very, very well-loved member of our medical community here. Has been in practice for quite some time. He's also the chairman of medicine for the hospital here, and that's Dr. Charles Guida. And Dr. Guida, thank you so very much for being with us. And Dr. Guida serves a number of roles at our hospital in addition to being one of our medical staff leaders. He's also a board-certified geriatrician, and today we're going to talk about geriatrics, which is a field that many people aren't, a specialty that many people aren't that familiar with, and certainly we should all be familiar with because we are all aging, and it's a field of medicine that would benefit many people very, very greatly. So we'll be talking to Dr. Guida about that in just a second. But Dr. Guida, first of all, I always like to hear a little bit. Tell us about yourself, your training, and how you ended up here out in Southampton.
Well, I was born and raised in Queens, and actually I did have a private practice there for a number of years. I did serve in an administrative and teaching role at the Jamaica Hospital. Okay. Then in 1996, our personal life changed. Our family became bigger, and being familiar with this area, we decided to explore this as a new place to live, and that's how we landed up.
Had you been out here vacationing previously?
Yeah, my wife's family had a summer home, so we would vacation and visit on weekends, so we were very familiar with the area.
Oh, wonderful.
And then an internal medicine practice became available. The doctor was leaving the area, and I was summoned and interviewed and started working here since 1996.
96, wow, that's impressive. And you've been, I know you're one of the most highly regarded doctors in the community, and it's just been wonderful working with you. So thank you very much for being with us. I know you're also serving as the medical director for the Hampton Centre of Rehabilitation and Nursing. Tell us a little bit about that.
Yeah, the Hampton Centre is a 280-bed facility for rehabilitation and long-term care. It's about 1.5 miles away from here. I've been there about 9 years, actually, as the medical director. We work very closely with the hospital. Many of the hospitalized patients that need subacute rehab do get sent there, and patients that become ill there are then transferred to the hospital and treated. So there's a lot of back and forth treatment of the same patients, and we do work together.
Yeah, and it's a very good facility, and I know for the community and certainly for us here at the hospital, it's wonderful knowing the facility is so close by because there are programs, and I know you even we utilize the facility for some of our training of some of our residents for the care of elderly people as well.
Indeed we do, and that's an opportunity for the medical and family practice residents to become exposed to nursing home care patients and the concepts of geriatric medicine, so it's a great opportunity.
Great, well thank you, and thank you for all you do. So let's talk about geriatric medicine, a nice segue into the topic. Just overview for us, what is geriatric medicine? I mean, obviously it's something to do with the elderly,
it has
but
something
yeah,
to do with
exactly.
The elderly.
Right.
The root of the word is actually of Greek origin, where geron means old man and iatris means healing, so it's really not healing old men, but the healing, the art of healing of the elderly, and it really grew into its own. I'd say we're in the 1990s where it became recognized as a needed subspecialty of family practice or internal medicine. I became board certified in the 1990s and recently became recertified.
Right. What age would typically be considered an appropriate age category for a geriatric patient?
Well, coming here at the wrong time, I thought maybe I would be appropriate geriatric.
I'm wondering myself.
Yeah,
right.
Many of my colleagues always come up to me and say, is it time? There's not a defined age. It's really defined by the patient's individual medical conditions that fall under the realm of geriatric medicine. Typically, the geriatrician sees patients in their 70s and more frequently well into their 80s.
Okay, so it tends to be more on the older side of the...
It tends to be on the older
elderly,
side,
right.
but certainly patients that are younger may have syndromes that would warrant a geriatric assessment. And that leads us to note that currently in the United States there are 7,500 certified geriatricians, and that's a very low number. The need is around 17,000.
Wow. So we've got basically a third the number of what we need. And with us baby boomers aging, I can imagine that's going to become even more severe.
It is. The baby boomers now, 10,000 every day are becoming age 65, Social Security, Medicare eligible, and they're entering into that sort of field of geriatrics. So the need is there. Clearly, we cannot meet the need immediately, so the philosophy in geriatrics is to train the subspecialties like surgeons and general practitioners how to act and think like a geriatrician.
Okay. Well, and I'd like to talk a little bit about the training. You mentioned that you have special board certification, and some lay people don't understand necessarily what that means and how do you get board certified. And doctors go through 4 years of medical school, but then they pursue residencies and additional training even beyond medical school. Can you just describe what happens for a geriatrician?
I'll speak from my route. After medical school, one would enter a residency program, and in my case was internal medicine, and the duration is of 3 years. And thereafter you can practice in internal medicine, or you can decide to subspecialize via a fellowship, which is another year or two of training.
Okay.
After you submit your qualifications and you pass a written test, then you are deemed board certified.
Right.
And then to maintain that certification, it requires you submit your continuing medical education credits and pass another written exam.
And how often do you have to do that?
That occurs every 10 years.
Every 10 years, okay. So it really does require you to stay current with what's happening in the field and the latest and greatest developments in the field as well. And it could be either internal medicine or family practice,
Family
you mentioned?
practice, yeah.
Okay, great. So let's talk about when a patient may decide it would be beneficial for an older patient to go to see a geriatrician. What would you recommend typically?
Well, the geriatric patient is a patient that has often comorbid or multiple medical conditions that are chronic. They're not necessarily curable, but they are present and they impact on each other. So the care becomes much more complex, and they would be best served by a geriatrician who really looks at the patient holistically.
Okay.
They are well versed in the normal physiology of an aging person. What brings the geriatric patient often is family members. They'll have family concerns. Some of the questions I hear in the office, well, mom just got home from the hospital. Is it safe for her to be home alone?
Right.
Does she need help? How much help? What kind of assessment can I do to determine that? Another question is, well, dad is getting lost driving the car. Does he have dementia?
Right.
Do we have to be worried? Are there any tests we can do? Another geriatric syndrome that we deal with are falls. Falls are often, or too often, common in the elderly. In the community, 1 out of 4 geriatric patients, meaning the age over 65, will fall in 1 year.
Right.
And it can be devastating.
Well, a question on falls. I mean, you hear about that and you think, oh, clearly a fall hurts, you could break a bone or something, but it does seem that falls trigger so many other conditions and issues with elderly. What's happening there?
Well, falls are often a sign or a symptom of another underlying condition.
Okay.
There could be a balance disorder, there can be an infection brewing, there can be a manifestation of another medical condition. Because patients are frail often and elderly and have osteoporosis, a fall can be a traumatic event. In the emergency room, every 30 seconds, an elderly patient is being evaluated for a fall. Right. And in this country, every 19 minutes, an elderly patient dies from a fall.
Okay.
So there's often an injury, and in 10% of the cases, the injuries are significant. A fracture, a hematoma on the brain.
Right.
So they're very serious events, and often they're the hallmark of the beginning of other things going on.
Okay.
So it's not, it's something we take seriously, and it's something patients don't report to you readily. It's estimated half the patients will tell you, and you really have.
They're embarrassed, or they're just afraid.
They're embarrassed, but I think it's part
denial.
of their what's happening with them.
Okay.
Or they may have forgotten.
Okay.
So when I see my patients, one of the routine questions I train my medical residents to ask, since I've seen you last, have you had an accident? Have you
Right.
fallen? Have you stumbled? And I'm still amazed how many say yes.
Really?
And then we get to the nitty gritty. It's kind of like being a detective. Did you fall because you tripped?
Right.
Did you start a new medication? Are you wearing bifocals, which is not maybe appropriate in
Right.
negotiating the stairs? So we kind of do our detective work to find out why.
Okay.
Falls can be prevented. It's not a lost cause.
Yeah, that's one of the questions, follow-ups I was going to ask you. We often think, well, we're getting older, we're going to fall. Is that the case? Or?
Well, the risk is there, but by doing an assessment, we can reduce the risk. An assessment includes looking at their gait and balance in the office,
Right.
testing their muscle strength, looking at their shoe wear, looking at their visual impairment, have they had an eye exam. Most importantly is looking at their medications. Is there a new medication or medication side effect? And we employ other services, other disciplines in the fall assessment. The physical therapist
Okay.
is a very big help. They actually go to the homes,
Right.
look at the houses, look for safety issues, and test the gait and balance in the home and make suggestions. Grab bars, get rid of the throw rugs, employ some lighting, things like that.
One of the things as I'm listening to you talk, it's clearly the assessment process seems different from a typical doctor visit, and you're both an internist and a geriatrician. And can you just contrast a little bit, like when you're seeing a geriatric patient, what is that assessment? How do you approach that patient? What's different in that initial interaction?
Well, the traditional internal medicine approach is to look at a disease. I see a disease, I see an infection, I'll give the patient antibiotics, they'll get better, see you next visit. It's much more complex in a geriatric patient because they have already coming with them other comorbid conditions. So the antibiotic you give may be not the right dose, may interfere with the medication. They may not be able to discern that pill from another pill. So as a geriatrician, we assess not only the disease and how we're going to treat it, but how it will impact on other diseases they have. Do we change the medicine dose because they have kidney insufficiency? So all these elements come into place. One of the things we like to do is engage the families to make sure that the treatment plan is completed. Right. And completed in the correct fashion.
Right.
So we do assessment of cognition. Are they able to understand that they need a treatment plan? And so it's much more involved than just treating the disease itself.
Sounds like you probably have to take a lot more time with the patient initially also than maybe a younger patient. So.
You do, and we try to allot sufficient time, and you can't accomplish everything in one visit, and sometimes right. You have to break the visits down so that you can approach each task adequately.
Do you find that it's an issue? I mean, I know even myself, when I started to have to wear glasses, it took me a long while to realize, my vision really is at the point I need glasses. We all go into this sort of a little bit of the ego. Is there a challenge sometimes to getting patients to accept the fact that maybe it's time for a geriatrician?
As I said, I think most of the referrals are coming via the spouses and family members.
Okay.
I think that's where they come from. And most of the patients are readily accepting that help because, as I said, most of them are experiencing issues
right.
that they're concerned about.
Right. And are there diagnoses that senior patients or elderly patients should be more concerned about than when they were younger, that they don't need to worry about as much?
Well, typically when you're younger, you may get a respiratory tract infection, you have a fever, you take some Tylenol, you drink some more fluids. On the elderly person, a fever, a respiratory tract infection could be the beginning of a very rocky course. It has to be taken seriously. Fever can lead to imbalance, it can lead to a fall, it can lead to delirium, which is an acute confusional state. So those aspects are a little bit different in geriatric patient.
Okay.
Temperature elevation should be taken very seriously. Hydration status should be taken seriously. So you have to be a little bit aggressively thinking when you're approaching these patients.
Just out of curiosity, without going into too much of the medicine, but what's essentially going on? Why at 55 is a cold not such a big deal, and at 65 or 75 or 85, it's really physiologically, there's something obviously going on.
Well, physiologically, one of the things that happens to us is that our physiological reserve to answer a challenge is diminished. And that's
Okay.
part of normal aging.
Okay.
Cardiac function, pulmonary lung function are diminished just by aging alone.
Okay.
So when those systems are challenged, it could be a serious problem.
You do hear people say as they get older, they just don't bounce back as
They
quickly.
don't bounce back,
Right.
yes,
Yeah,
yeah.
it seems to be.
Yeah.
What about diseases like Alzheimer's and dementia, and why are those more common in geriatric patients?
Well, Alzheimer's and dementia, and Alzheimer's is one of the types of dementia, is the most common. It affects 5.5 million Americans,
Okay.
and that number will grow by the demographic growth of that population.
Right.
The risk factor for Alzheimer's disease is age itself.
Okay.
So it's an older person's condition. We do see it occasionally, but not often in younger people. So it's really a disease of aging, or of the aged, and it is one of the most common concerns that family members will bring to my attention
All right.
about memory loss, and does this represent dementia? Is this Alzheimer's, or is this part of normal forgetfulness that's benign?
Right.
We do have testing
All right.
for this, and I'm happy to say at Southampton Hospital, recently we do have a PET scan. It's called an amyloid PET scan.
I was going to ask you about that. What is that, and what's going on there?
Yeah. So the patients with Alzheimer's, they found over years of research, they have an accumulation of an abnormal protein called amyloid
Okay. This is in the brain, right?
in the brain.
Okay.
The PET scan, the amyloid PET scan, is able to detect it. So if a patient undergoes this scan to determine whether they have a benign forgetfulness or maybe the beginnings of Alzheimer's, this helps us decide what road the patient is taking and helps us decide if an intervention is appropriate.
When you say benign forgetfulness, what do you mean by that?
Well, this is the kind of thing, you may forget your car keys at home, you go back and you get them,
Right.
or you walk into a room and you say, what did I walk in this room for?
Mm-hmm.
What we're looking for is, well, you forgot you took your car to the store,
Right,
or you
okay.
get lost going home, or you start, you kept a checkbook perfectly and now you're not.
Right.
So we're looking for really how it's affecting your functional level.
Okay, so almost like a degradation in real function and things. And
Function is a key word in geriatric medicine.
we all suffer, I think, from occasional bouts of forgetfulness on little things, but it's any sense that you have that if it's becoming, I guess it's almost like the severity of the forgetfulness rather than the incidences of it. I mean, there's some people that are naturally forgetful all their lives, but is there a difference in your perspective?
Well, there are other domains in Alzheimer's disease that are effective, cognition, executive function. There's also an association with depression, loss of interest in doing hobbies, less social interaction, the ability to calculate numbers, do drawings. So when we do these cognitive tests, we look at different domains, not just forgetting things.
Okay.
Yeah.
And while I know there's no cure for Alzheimer's, somebody once asked me, well, what's the point? You can't do anything about it. Is that true? Are there things we can do about it?
Well, there are medications. Unfortunately, their effect on the process is rather modest,
Okay.
unfortunately, and
Yeah.
that's the truth. But it allows families to make plans, and it allows a patient to make plans.
Right.
They may want to do things financially in their personal life. They may want to make amends with family members. They may want to do things to prepare for the future.
Right, right.
So there is benefit. The old idea, well, let's just hide a diagnosis, is not really helpful.
Right.
It allows families to say, well, you know, mom and dad need this amount of help, and you know, in a few years they're going to need more help, and this is what we can do ahead of time.
Help them prepare. Exactly.
Help them prepare.
You mentioned depression. Is that something you see more of in the elderly also?
One of the things, that's hard to determine. I think
Okay.
it's more prevalent. It sometimes presents a little bit atypically.
Okay.
In fact, sometimes dementia or depression can look like dementia. So that should be discerned, because treatment of the depression often improves the cognitive ability of the patient.
Okay. Okay.
I also mentioned delirium. Delirium is an acute confusional state. We see it most often in the hospital.
All right.
Elderly patients go to the hospital, 30 to 40% will have a bout of delirium.
30 to 40. I had no idea it was that
Yeah.
high. Wow.
And the typical story is patient comes in with a medical issue,
Right.
doctor takes care of that medical issue, let's say pneumonia, and then 3 days later they want to discharge the patient home. And the patient has an acute delirium. Well, what happened? So we look at that and we say, well, the patient hasn't been out of bed.
Right.
They received new medications. They got a sedative. They became incontinent in the hospital because they couldn't get to the bathroom. They actually got dehydrated. And a physical therapist didn't assess that patient and get
Right.
them out. So one of the benefits of having an ACE unit beds in the hospital is to use the multiple disciplines to approach those patients in the hospital.
Yeah, and I'd like to talk about the ACE beds, but I also know the hospital environment's a tough place to sleep, and the lights and the monitors and all the other issues often can create issues as well, right?
Exactly.
Just changing subjects a little bit, because I know one of the things people are very organized or very interested in is vaccines, and we're hearing about new vaccines that are specifically targeted toward the senior population. Can you just talk about that a little? What are some of the vaccines you would recommend for your patients?
Well, some of the vaccines, and this is my personal opinion, but number one, it would be the influenza vaccine. I
Okay.
think that's an imperative. There's no reason not to get the influenza vaccine.
I've heard there's a new senior version or elderly.
There is.
Yeah.
Some of my patients call this the high test, the premium. It's been out a couple of years, and this is called Flu Zone.
Okay.
And it contains 4 times the amount of the antigen. Now,
Okay.
antigen is a protein that stimulates your body's antibodies.
Okay.
And it's much more effective and efficacious in preventing the flu.
Okay.
So that's my preference, and that's a yearly vaccine,
Okay.
as the virus does change its coat, and it may not be the same as last year.
Right.
The other 2 vaccines, or actually 3 others that I consider important, there are 2 for pneumonia. One is the traditional pneumococcal vaccine, and the other is Prevnar. One does not substitute for the other. They should be
Okay.
given at some point in your life, and preferably the Prevnar you get first, and then 1 year later the pneumococcal. So those are the big 3 that
Is
help.
that because there's different kinds of pneumonia, or why?
There are different
why
kinds
are
of
there 2?
pneumonia.
Okay.
That's the CDC recommendation.
Okay.
They kind of complement each other, and those are the recommendations. And lastly on the list is the infamous shingles vaccine.
Right.
Currently, there's 1 vaccine out. It's called Zostavax.
Okay.
The current recommendation is to get 1 shot in your lifetime. But this week, and I believe it was just 2 days ago, the FDA has approved a new vaccine for shingles.
Okay.
And this is very exciting because the Zostavax had a efficacy about only 50%.
Okay.
The new vaccine has an efficacy of over 95%.
Wow.
So it's very, very exciting.
Okay.
We'll see what the recommendations will be in terms of what age should you get it if you had the old vaccine. Do you need to be revaccinated? I do know it will be two shots,
Okay.
several months apart, and I expect it to be out quite shortly.
Quite soon. And
Yeah.
at what age should people start thinking about these vaccines?
Yeah, the Zostavax, which is the vaccine that's available now for
Right.
shingles, is recommended age 60.
Okay.
And that's when you have the most robust reaction to it in terms of building up protection.
Right.
If you get it in your 80s, it's not as good.
Okay. And shingles vaccine, I've always been a little confused. Why? I know it's related to the chickenpox virus, right? And but if you've had chickenpox, why do you need the vaccine?
Yeah, interesting. Well, this is a unique virus. It is caused by shingles, is by the smallpox virus that we get as children.
Okay.
And
Or chickenpox. Right?
Chickenpox.
Yeah.
Chickenpox.
Yeah.
And chickenpox, you get better from it, but then the virus lays dormant in your nerve root.
Okay.
And then for reasons we're not so sure, it comes out as a blistering, painful rash.
Okay.
And that's known as varicella zoster. And it's really the re-emergence of that chickenpox.
Oh.
So you don't get, as shingles, you can't get shingles from somebody. It's already in you.
I see.
So the vaccine helps build up antibodies so it keeps it in check.
I see. And why over 60? What's happening? What's so magical about the 60 that suddenly you're more susceptible to shingles?
Well, at age 60, it's 1 in 3.
Okay.
And that's the reason the CDC made that recommendation. Other agencies have actually lowered it to age 50.
Okay.
So there are different players in the recommendation world of vaccines.
Okay. You mentioned the ACE unit, and I'd like to just, before we run out of time, I'd like to talk a little bit about what is the ACE unit at the hospital and why do we have an ACE unit?
Well, I'm excited about it. The A stands for acute care for the elderly. These are designated beds in the hospital. They're designed to accommodate the geriatric patient with an acute medical illness. The room is quieter, it is larger, it can accommodate family members, which we encourage. And it engages, when a patient is admitted to an ACE bed, it engages the services that are very important for that patient to have a successful hospitalization. And that includes the social worker, of course the nursing staff, physical therapist, occupational therapist, the nutritionist, and the pharmacist. And they're all important players to look at that patient and make sure that they get out of bed, they don't sit in bed, that the medication is the right dose at the right time, and there's no drug-drug interaction. Nutritional status of the patient is assessed, which is often neglected, and patients getting better really require to have good nutrition.
Right.
So it's, and it's been proven in other hospitals. It's not our unique idea, but I think we're one of the few hospitals that have on East End the ACE units. It has been proven to decrease the length of stay, decrease the incidence of being transferred to a nursing home for rehabilitation, and decrease the incidence of delirium.
Okay, the delirium you were talking about.
Yeah.
Right. Physically, the environment's a little different?
It's a little bit quieter, the lighting
Okay.
is different,
Okay.
the clocks have large numbers on them, things of that nature. The lights go on automatically when a patient passes through the doorway to go to the bathroom,
Okay.
things of that nature.
Yeah, I know that we worry about falling in the hospital for senior, all patients, but
All
particularly
patients,
senior
yeah.
patients. So one of the other questions before we finish up, just medication management and an advantage to seeing a geriatrician is that you talked about this whole approach, and that's an issue as well, right? Making sure that we understand all the medications.
Yes, polypharmacy is one of the geriatric syndromes we think about. Patients not only take prescription medications, but they take prescription medications from different specialties. And doctors may not be aware that another doctor has prescribed a certain medication. And then there's a slew of over-the-counter medications that were prescription medicines that carry their own risk. So we do what we call the brown bag assessment. We ask the patient to bring in, not the list, but the actual bottles of everything they possibly could be taken into the office. And we go through it by one. That's a pharmacy reconciliation. And it should be done every time there's a transition. So when a patient leaves the hospital, it should be done, or they get discharged from a nursing home, it should be done. And we do it at least twice a year in the office.
And isn't it true that, at least I've heard that geriatricians often will try to wean patients off of certain medications because the patients may not know that they're having a reaction to some of these?
They may not know it, or the benefit may not be, the risk may be greater than the benefit of the medication. Okay. Certainly patients in their 80s taking cholesterol medicine has to be reevaluated. Right. In terms of the goal of treatment. Sometimes we don't need to vigorously treat every ailment with a medication. That's again where, number one, the pharmacist helps you out. The community pharmacist is a great, valuable tool and asset. And also in the community, the physical therapists try to work with pain syndromes through therapy rather than medications.
And just the final question, because we are out of time, unfortunately, but personally, what do you find so rewarding about geriatric medicine?
To me, well, I like to read detective stories, and I think being a geriatrician is like being a detective. Okay. And I think that's the appeal for me. And there's a lot of satisfaction in actually taking away your medicine and the patient gets better. Right.
I'm sure some of your colleagues wouldn't be happy to hear that, but I think that's wonderful. Well, Dr. Guida, thank you so much, not only for spending some time with me today, but also for all the great work you do at our hospital, the nursing home, and in this community. We're really lucky to have you out here.
I appreciate it. Thank you.
And I'd like to thank all of you for watching us today and being with us. And as always, I'd like to thank our friends at CTV for producing and airing this program in our Southampton communities, and our friends at LTV for airing the program in our East Hampton communities. I'd also like to invite any of you that have any questions, concerns, would like to contact Dr. Guida for more information. His office is at 631-283-2100. He's part of the Meeting House Lane Medical practice here in Southampton, across the region. Wonderful practitioner. If you would like to contact him, please do. We will also, if you need help navigating our healthcare system on the East End, as always, please feel free to give my office a call at 631-726-8555. Thank you, everyone, and good health.